Students, colleagues, faculty, staff, community nurses, we're so grateful that you've joined us for our third and final session of our 16th annual School of Nursing Research Symposium, and the first time we are in a webinar format. We've had some questions about continuing education and our virtual hall of posters. We want you to know that you can access them on the website that you have, and that those posters will be accessible until May 21st. If you attended all of the sessions and completed 6 poster evaluations and all of the evaluations for the presentations, you would qualify for up to 7 continuing education contact hours. Because we're giving this extended time till May 21st, we will figure out this, we will develop the certificates at that shortly after the 21st, and they will be emailed to you after that date. As we've done before, the chat function in Zoom is disabled. And so please submit all your questions and or comments in the Q&A section of Zoom. And participants, we encourage you to submit those questions and comments as early as possible. With this number of people, we have faculty hosts who will be summarizing questions and comments for the speakers. Tonight, we are very fortunate to have 2 distinguished speakers, Dr. Patricia Benner and our Dean, Dr. Lesch. Both of them are well known to most of you. And so we'll begin now by asking our Senior Associate Dean, Dr. Renee Poza, to introduce our first speaker, Dr. Benner.
Thank you, Dr. Wood. Good evening, everyone. It is my distinct honor and pleasure to be able to introduce to you Dr. Patricia Benner. Dr. Benner was actually a faculty member of mine in my PhD program at UCSF, and we have many fond memories of philosophy of science together. So let me tell you a little bit about Dr. Benner. She's a professor emeriti at the University of California School of Nursing. She is a noted nursing theorist, educator, and author of From Novice to Expert, Excellence and Power in Clinical Nursing Practice, which has been translated into 12 languages. And I know many of you have read this book, maybe even several times. Dr. Benner is a graduate of Pasadena City College, UCSF, and UC Berkeley. And she has been a mentor to many nurse leaders, clinicians, and nurse educators, and has directed over 50 doctoral dissertations. She pioneered the use of interpretive phenomenology in nursing and is well known for her description of stages of learning and skill acquisition across the careers of nurses. She recently completed a nurse faculty survey on transition to online teaching and learning during the COVID-19 pandemic. She is the director of the Carnegie Foundation for the Advancement of Teaching, National Nursing Education Study, Educating Nurses, A Call for Radical Transformation, which is the first such study in 40 years. Additionally, she collaborated with the Carnegie Preparation for the Professions Studies of Clergy, Engineering, Law, and Medicine. Dr. Benner received designation as a living legend of the American Academy of Nursing, was elected an honorary fellow of the Royal College of Nursing and Danish Society for Nurses. Her work has influenced beyond nursing in the areas of clinical practice and clinical ethics. She has received 2 honorary doctorates. She is the first author of Expertise in Nursing Practice, Caring, Ethics, and Clinical Judgment with Christine Tanner and Catherine Chesla, and has co-authored 12 other notable books, including a second edition of Clinical Wisdom and Interventions in Acute and Critical Care, a Thinking in Action Approach. She is the executive director of educatingnurses.com and a co-founder of Novice to Expert, of which many of our students have gotten to know over this past year. Dr. Benner, we are very honored to have you here at APU and look forward to your presentation. Thank you for being with us.
Thank you, Renee, and I remember fondly those philosophy of nursing classes. I'm going to share my screen now, and Okay. So,
Perfect.
okay, now I just need to advance it.
You can click on the screen or use your own keyboard arrows if you like.
Oh, keyboard hours. Good. Thank you. I always freeze in the moment here. So we did a survey of 290 faculty on the impact of rapidly moving to online teaching, which was required by COVID. And the two top challenges that faculty reported was keeping students engaged in class and in the courses. And that's not surprising. That is one of the major issues in all online learning, is keeping that engagement going. So students, we found, were stressed out not only with school and requirements to meet those school standards, but they had children being homeschooled, as many of you know. They also had loss of employment of one or both parents or partners, and worries about attending clinical sites and bringing COVID home to their families. One of the faculty members said, I urge financial support as well as counseling and social services to assist students and their families so that they can continue to be successful in their program. So moving rapidly online was a challenge for the students, and it was also a challenge for faculty members as well. Student engagement, Joshua Eiler points out in his excellent book that goes through learning science, that whatever the format, whatever the context, curiosity, sociality, and that's gets removed when you lose your face-to-face classroom, emotional connection, authenticity, and failure are essential for learning, whatever the format and context. I want to say a little bit about each in terms of the implications for online teaching. Curiosity is natural for human beings. You have to have a really good reason for not being curious. If we had a big sound go off, we would all immediately be curious. We've been around young infants and we see curiosity is just so part of what it is to be human. But somehow our pedagogies sometimes dampen curiosity. We sometimes teach as if everything is always already known, and we dampen curiosity. Online teaching, keeping curiosity alive and keeping teaching and learning inquiry-oriented is even more important. You have to really work hard in online education to build in social connection, small group learning, and interactions so that students are not only engaging with the teacher, but they're engaging with one another and they're teaching and learning from one another. Emotion, we get a little scientistic sometimes, and we imagine that we really, I want to go back, let's see, I want to go back to that last slide. We imagine that our goal is always to be objective, detached, as if we're engaging in a scientific experiment. But neurocognitive science has taught us that without emotional connection to the world, if you have some frontal lobe injury, you don't have the possibility of rationality because the world loses its tone and its shades, its nuances. And you can't, without the fuzzy recognition of emotion, you lose rationality. And we in the West have often split emotion and feeling from thinking and knowing, but that's not accurate in terms of how we learn. Authenticity. It's so important for the teacher to present authentically and with real questions and conundrums and puzzles and inquiry. And no one likes to think about or talk about failure, but in fact, Gadamer points out that all experience is based on a turning around of pre-understanding or preconceptions. And if you are so focused on certainty, you won't be very good at being turned around and learning from failure. One of the things that we noticed early on at that proficient stage of skill acquisition is that suddenly the narratives were saying things like, I went in thinking this was going on, but that wasn't what was going on at all. So you get these turnaround kinds of experience, and that's a very good sign that someone is on their way, they're in proficiency stage, and they're on their way to expertise. Community of inquiry I really recommend this FIOC article on community of inquiry for thinking about your online teaching. And what they encourage in this article is that there be a strong cognitive presence about the issues that are and the ideas and the theories and the science, the technology, the philosophy, the questions, that there be a strong cognitive presence in the course, but also a strong teaching presence. And one of the recommendations that they offer is that the teacher offer frequent, very targeted 5-minute handmade, homemade videos to stay present and have the student feel the teacher's presence, which would happen if you were in the classroom. Social presence of all of the students and the teacher is equally important for these to create a community of inquiry and a community of learning. The second major challenge was finding online learning resources to replace unavailable clinical sites. And here I will give you 2 major resources, and I'm trusting you'll have access to the slides so that if you want to follow up on these, you can do that. But these are 2 excellent reviewed resources for clinical replacement and simulation that you can use. We found in the Carnegie study that we're doing a good job in the classroom teaching knowing about and knowing that. In other words, the sort of theory, the science, the technology. And that currently predominates in classroom and online teaching. But the problem with that is students are inexperienced and they lack the clinical imagination to link knowing that and knowing about to knowing how and knowing when. And here I want to really push you to get beyond a narrow rational calculation kind of view that application is mere one-to-one putting something into practice, because actually situated thinking, situated cognition about knowing how and when are forms of higher order thinking. They are not mere application. I would like you to trade the word application for knowledge use, because knowledge use in particular clinical situations is a higher order form of productive thinking. So one of the major challenges that we found in the Carnegie study was this huge disconnect, both in classroom and online learning, is that the classroom and online presentations weren't well connected with knowing how and when and understanding and practice. And that's a major problem for beginning and novice first-year nursing students, because the faculty has to remember that the student doesn't have experience to connect for implications. And so the faculty member for the novice student has to be a really superb ethnographer, a cultural anthropologist who can guide astutely the student's understanding and imagination about the nature of whole clinical situations, because they don't yet have the background experiential wisdom to do that on their own. The other thing that we are not doing, we found in the Carnegie study, we're not doing teaching for clinical reasoning. And here I want to point out that the nursing process is swimmingly fine for the first semester, maybe even into the second semester of nursing school. After that, it should be jettisoned. Because clinical reasoning is a form of practical reasoning through transitions. So it's always about comparisons and contrasts. The nursing process is a snapshot form of reasoning that tries to yield yes or no answers at particular points in time. And yet when you're doing clinical reasoning, you're reasoning across time about changes in the patient and or changes in the clinician's understanding of the situation. And we really need to improve our pedagogical strategies for teaching clinical reasoning. For clinical reasoning, you need unprompted responses so that the student and the nurse gets practice in choosing the most urgent and high priority interventions. I don't have this word salience on here, but what I want to point out is that early on, you want to teach so that the student begins to understand some things just stand out as more important or less important. And sometimes we move into an intellectualist notion that everything is element by element and explicit assessment by assessment, but no nurse could function if that were how they were really operating. They get a perceptual grasp of the nature of the whole clinical situation, and that's how they deal with the limits of formalism. You also, in order to teach clinical reasoning well, you need immediate feedback on responses. And that's hard to deliver sometimes in actual clinical practicum, but in an online simulation course, you can do that. So when you teach for clinical reasoning, you want to discover misinformation, mistakes, multiple diagnoses, interactions between diagnoses and treatments. And you want to improve the narrative memory and the clinical imagination of the student as they develop their embodied, intelligent agency so that they feel the responsibility. I was always so amazed to study the new graduate nurses because it was always as if some switch had been flipped, that I wish we would have been able to make that switch happen in the senior year, because they felt the full load of the responsibility of being a nurse, of rescuing, of not making errors, of catching important early warnings or changes in the patient across time. So in order to teach clinical reasoning, you need a dialogue between the particular and the general, and unfolding cases that are authentic with real lab results, real times, patient vital signs, again with real times, tests and sequencing of clinical events are really essential. A flat template case study doesn't cut it. You need something that is showing this change across time. So when students can actually compare from their own experiential learning whole concrete cases, that's where you want to direct them, because that's much superior than trying to always work off a list of signs and symptoms that you can get from a textbook. That's where you have to begin, but where you need to go is that experience-based, very high fidelity, recognizing nuances, subtleties, changes in particular clinical situations. So Azusa Pacific has been using NAVEX, which meets all of these criteria. I mean, the program is focused on clinical reasoning across time and developing a perceptual grasp of the nature of the whole situation and developing a sense of salience about what is most important and least important. So the student is taken into, this is only a slide and not a live internet picture, but the student is taken into a room where they can get the patient's complaints, history, how they're currently feeling. They can get all of the lab data and the monitoring, and that is always absolutely authentic and real. They must figure out when it's safe to finish the case. They will get immediate feedback about the medications they choose, the labs they choose, and there's no avatar involved. It is the nursing student or the nurse who feels responsible and is the agent, the embodied intelligent agent. So what we found with this wild year of experimentation with clinical replacement, we found that most schools are saying, this is a bridge between classroom clinical simulation and clinical rotations. So you don't have to just depend on that lack of imagination and the lack of experiential learning in the classroom. You can build together clinical simulation, and clinical simulations are particularly good for interpersonal communication, a lot of things that you can't interpersonally create so much online. And clinical rotations. We find that when students have practice with unfolded, unprompted clinical reasoning in the NAVEX simulation, they do much better in their clinical rotation. It seems to bridge that gap between the classroom and the clinical. There's a lot of interesting research coming out on this now. Kim Layton and Susan Carding Edgren and Angela McNeilis and others have looking at the lack of measurement of clinical outcomes from clinical rotation. So I think one of the things that COVID has taught us is that we have a great need for really evaluating what is essential to be taught in clinical rotations. How can we enrich and augment clinical rotation education and make students' minds really prepared by practicing clinical reasoning across time about particular clinical situations. So I'm going to stop there, and I look forward to hearing your questions and and thoughts about this. Also comments perhaps on your own experience of moving into online education. I don't think we're ever going to go back to where we were in the past. I think we're now going to have much more hybrid of clinical simulation, clinical rotation, and online clinical reasoning programs, so that we get beyond that static, flat case study, and we really move into more vibrant, high fidelity, unfolding clinical cases in order to teach clinical reasoning.
Thank you so much, Dr. Benner. I can hear the students cheering when you said that we ought to jettison the care plans.
Well, care plan and also the nursing process. That mimics the scientific process. It's a snapshot point in time that tries to yield yes and no decisions. It is not a compare and contrast through changes. And so we really have to improve our pedagogies on teaching clinical wisdom.
Yes,
clinical reasoning, sorry.
Yes, and that's part of what this question is asking. How can the difficulty in addressing clinical reasoning in clinicals be improved to complement the teaching that would be done in an online format?
Well, I think inquiry, I think also situated coaching. The very best clinical instructors we observed in the Carnegie study were so thoughtful about every particular clinical assignment, and they designed questions for that particular patient with the student. And they also were really astute coaches on coaching the student for a good perceptual grasp of the nature of the whole clinical situation. And it's that we call teaching for a sense of salience, so that what's different about a human expert and a old-fashioned artificial intelligence, which failed. I mean, we are now into a new generation of artificial intelligence, of neural nets. But if you have to formalize everything, and if you don't have a sense of what's most or least important, if you have to stop and figure out respiratory arrest is your number one priority in this situation, you're already too late. So this ability, much like the cultural native, to read a terrain, to read a situation, that's what clinical reasoning requires. It requires understanding the nature of the whole clinical situation. And that's what often that novice, well, they simply don't have the experience base or the imagination. So one of the great examples in the Carnegie study was this freshman student was taking literally the admitting diagnosis and assuming that that was going to not change, over time, because it said that in the chart, right? But of course, this patient who came in with urinary tract infection went on into full-blown sepsis, and the admitting diagnosis was obsolete. Those are the kind of blind spots that the novice really struggles with. And it's only through astute, situated coaching that they can enlarge their imagination and their perceptual grasp of the nature of the situation, and eventually develop a sense of what's most important, least important in a situation. And it's that nuanced, valenced world that you're trying to help the nursing student develop. And it's a long journey, right? It takes a lot of direct experiential learning. And one of the things that's so important in teaching is to help the student give public language, to articulate clearly what it is that they got turned around in their thinking. What did they learn new? It's so important not to say, look, okay, that was a really rich experiential learning. Now let's concept map that, as if the concepts were the only possible knowledge. That freezes uncovering discovery and things that might not really show up well in terms of sequencing and interaction in a concept mapped at all. So that taking seriously frontline experiential learning, if the faculty do not take it seriously, students won't take it seriously, and they won't be as good at learning directly from practice as they would be if we considered practice as a way of knowing in its own right.
It sounds like some of this would also help anticipate complications and other things that we need to prevent as well as treat.
Right, it would really, this is where you develop early warnings, and you discuss early warnings. When, 30 some years ago, when we first brought up our observation of nurses doing early warnings, there was a kind of backlash, and it was kind of a strange language. It's no longer strange, but at the time, there was the rhetoric, well, the doctor makes the diagnosis. Well, the doctor doesn't make hardly ever, a diagnosis that isn't framed and informed by the early warnings that a nurse is seeing. I teach all of my students that, especially nurses who are practicing, you need a language of ambiguity at times. Look, I don't like the way this patient is looking. The vital signs haven't changed markedly, but something is not right. You need to come and do a full-on examination of this patient. You don't always have to have the definitive SBAR. You can use ambiguous language to describe situations of early changes. We know there's always a compensatory period in shock, for example. And so learning to expect and grasp those perceptual changes that are subtle early on is so life-saving. But we sometimes teach as if everything is always certain, or that you can definitively know everything. No, you have to be a great puzzle solver. You have to stay curious.
Beautiful. Thank you so much, Dr. Benner. So here's a comment followed up by a question. I heard you mention early on the topic of cognitive presence and how important it is to facilitate learning. What is an example of a learning activity related to cognitive presence?
Oh, so many examples come to mind where you take an issue. For example, like one of the important things I want every faculty member now to teach after using NAVEX and seeing how many new graduates have sentinel events, because they don't distinguish between a hemorrhagic stroke and an occlusive stroke. And so they give the wrong medication. They often give it in the wrong route. So a cognitive present would really explore the clinical implications and why this is so very important. In the NAVEX online simulation, in our lessons, we always contextualize, we always point out priority and urgency, and we always point out the clinical implications, because for the novice, it's not possible, because you haven't lived through enough futures to imagine what might happen, or to immediately grasp what are the clinical implications of a hemorrhagic stroke versus an occlusive stroke. So to deeply understand, and also to be able to form a dialogue between the particular, which is where the clinician in relation to the general, which is where the clinician must know about, but to understand that that's a real dialogue, and no one just has one medication or one diagnosis with no interactions and no changes along the way.
Thank you. Let me go ahead and give you another question here. Someone had said that they really appreciated your sharing in your presentation. Do you have advice for us as students to study better in online classroom?
Oh, well, you have to bring a lot to online learning, commitment, engagement, and you need to be able to reach out to other students, other learners. That's what will give you a real incentive and spark your curiosity. In a classroom, you know, you prod one another without ever thinking about, well, have you started the assignment yet? I'm so confused about this assignment. All of those comments drop out when you don't have that face-to-face interaction. So the student really needs to build that in their online learning. And while the teacher needs to build for curiosity, build from learning, it can't rest with the teacher alone. It has to really come from a very motivated student that will give it the extra attentiveness, the extra curiosity, and the extra connectivity with other students that it really requires to do well in online learning.
Great. Okay, here's another question for you. Oh, someone's moving in for me. The pandemic has disrupted how clinical practice is done. What do you think is the best pedagogy to be used in developing clinical reasoning for students?
Oh, well, I do think the unfolding cases, I do think these unprompted authentic clinical cases with NAVICs are really helpful. I mean, we've really shown huge learning and performance outcome gains from taking them. But I think, oh dear, I've lost my train of thought. Go back to the question again, because there was.
Okay, absolutely. Well, I'd love to go back. Let's see here. Unfortunately, I think someone has taken it off and I can't see it.
Okay, but
I can give you the question again.
Okay, okay.
It says the pandemic has disrupted how clinical practicum is done. What do you think is the best pedagogy to be used in developing clinical reasoning of students?
Oh, well, I do think to integrate clinical and classroom as much as you can, to put together knowing that and about with knowing how, and that situated thinking is so very important. But the thing that I really want to emphasize here, after interviewing and observing and talking with nurses, what nurses have learned frontline about the nature of this virus and its many manifestations, we simply didn't know a year ago. And we have a huge articulation job ahead of us to capture all of what frontline nurses have learned in managing respiratory distress with COVID patients. And I hope that we will figure out ways to capture this frontline knowledge development in the time of COVID. Think of all, I was very moved and impressed by the New York Times video where nurses wore cameras in Arizona and talked about, you know, all that they had learned in working with families, of course, who couldn't be present, and how to make those connections between families. But what I took away from that, and you can find a write-up on educatingnurses.com on this, is one of the most exquisite examples of skills of involvement and engagement by these nurses in Arizona. They were so attuned to the families, and they were so inclusive in those telephone calls and meetings and connections. They just went the extra mile, and they weren't self-focused. They were focused on the demands of this awful, awful illness and the demands on the family. And so at the end of the interview, at the end of the video, the interviewer asked, well, what advice would you give to other nurses? And what would you say to them if you could talk with them? And she just said simply, thank you. I would say thank you. And that moved me because it shows the respect for the difficulty of the work and the human necessity of this kind of frontline courageous caring at the risk of one's own life. I think it's a moment of pride for nursing, but not pride in a in a puffy way, but a moment of, yeah, we did that. It was really hard, and we learned so much. And now I think our challenge is to capture and articulate, give public language to, because we could generate so much research based on frontline clinical learning if we really took seriously how practice is a way of learning and knowing in its own right.
Mm-hmm. Thank you.
Let me refocus us a little bit on student learning here. This comment was made by someone who said, students don't seem to want to understand clinical reasoning. They often won't take seriously and just quickly click through, I assume that meaning the online kind of work, and there's no way to ensure that they've read the material first. How can we get them to come prepared and also get support from class instructors?
Well, if you use NAVEX, there is this wonderful analytic program. So you can follow every decision your student makes. And if the student is cheating, frankly, by going to what the outcome of the case is, the program has a built-in flag for that. And the teacher needs to work with the student to stop doing that. And usually once they're discovered, they do stop. But there's a built-in accountability with that analytic program in NAVEX, in that if the student is confused about hemorrhagic and occlusive stroke, it shows up in the click stream. You can identify groups of students who are missing the mark, who do not understand something. This has been such a burning issue for me since I was in the Carnegie study, because when the math teachers would come in, they could diagnose the missed logic of their math students, where they took the wrong turn. Well, with the analytics of looking at the decisions students make, you can see where they misunderstand, where they don't have a good perceptual grasp of the nature of the situation, where their sense of urgency and priority is off. And then the program sends them back when they get a wrong answer to the lesson. And that's really important, because we know our students are typically speed readers, text messengers, and we really have to prod and encourage in-depth reading. And we get lots of pushback from students who are saying, oh, I got so tired of being sent back to the lesson. But it's the only way I would have learned this, because I didn't fully grasp it in the beginning. So I think that kind of iterative learning that you can do in an online simulation is very useful. And the performance outcomes show it. But I think one of the things that happens when a student makes a very bad mistake and the patient is injured or dies, the screen lights up and they begin to feel the weight of making wrong clinical decisions. And I think that's the learning by failure, and can be very powerful.
Thank you. We have one more question. And this writer has said that at the moment, student nurses in the Philippines are not allowed to have their actual clinical rotations. So schools of nursing have shifted to the virtual format through provision of case studies. What advice can you give to nurse educators in making sure that clinical reasoning is developed in the absence of actual clinical experience? Thank you.
Well, I do think that simulations help. I think the online unprompted teaching and that forces the student to reason across time through changes in the patient, and to be the one to make those clinical decisions is really critical. For example, we never in NAVIX give the diagnosis. We say, assume that you have all the orders you need to do to treat this patient. But we want to keep the student in that front line of thinking, which they will be as a nurse. They will need to be able to discern when they get poor orders or that there's a faulty diagnosis. And so I think the more responsibility they have for solving the problem directly and to actually reason across time, the more powerful their learning will be, because that's their destination. That's where they have to get in order to be practice ready.
Looks like a couple of more questions have come in, so just bear with us just a moment. This particular person says, why did it take the pandemic to show hybrid learning can be somewhat beneficial to nursing? We already see working LVNs and RNs that go back to school and are successful doing hybrid learning. Why wouldn't this shift be made already if there is a nursing shortage?
That's a brilliant assertion as much as it is a question. You're absolutely right. I think we have learned a lot. We've certainly learned a lot about integrating classroom and clinical teaching with the hybrid learning, with online learning. And we've also learned a lot about small group learning and really enhancing when you mix students who are at the top of the class and who are struggling, everybody rises. It's amazing. Not just the ones that are not doing so well, but the ones that are doing very well do better. So I think we really have to take seriously the lessons that we have learned from the hybrid learning during the pandemic. It certainly requires, and I really encourage all nursing schools to get good instructional design specialists to help with maximizing online learning development, online course development.
Actually, this question kind of fits into this topic right here. It says, will there be a switch from the traditional classroom knowledge-focused learning to more clinical reasoning because a pushback from students is focused on feeling of added schoolwork to an already intense workload present?
Well, we do have a problem of overload, and cognitive overload is one of the major problems in both classroom learning and online learning. So we have to be very thoughtful about our curriculum choices. We can't teach everything, but we cannot allow our graduates to graduate without being absolutely practice ready in relation to sepsis, cardiovascular, stroke, all of the most frequent kinds of things, COVID, the things that they will encounter in their practice. So we have an obligation. We've got a long ways to go. One of the sad things that's come out of COVID is that we have research showing that we have nurses graduating who are less practice ready than before. And that's a huge credibility gap for faculty in schools of nursing, that we cannot sustain excellence if we do not improve the practice readiness of our graduates.
That's it for questions. So let's transition. Brett?
Thank you so much, Dr. Benner, for your excellent presentation and your words for us. And thank you so much for your commitment to excellence in clinical nursing and to the impact your work has had on nursing education and certainly the development of the next generation of nurses. Now I'm going to transition and introduce our Dr. Aya Toloners-Lesch, who serves as the Dean of the School of Nursing and professor at APU School of Nursing, and she's also my boss. She earned her BSN and her Master's in Nursing from UCLA, and her PhD is from Claremont Graduate School. She is a women's health nurse practitioner from Cal State LA and has held clinical positions both in acute care and in primary care. During her 15 plus years as the Dean of the School of Nursing, she's expanded us beyond the traditional BSN program, starting extensive graduate programs, entry-level masters, the MSN with advanced practice specializations, our MSN in nursing education, our healthcare administration program, fellowships, as well as our PhD in nursing program and the doctorate of nursing practice. I'm amazed at the growth that we've had under her leadership. She also has a passion for international health and has traveled extensively to support the professional expansion of nursing in areas such as China, South Africa, and Vietnam. She develops study abroad opportunities for our nursing students, as well as short-term exchange opportunities so that nurses in other countries can come study with us and develop research collaborations. In addition to her role as an administrator, she's a clinician and an educator and a researcher with an extensive background in research in maternal child health, community, and mental health. Over the years, she's been the principal investigator of studies and received over 25 million in state and federal funding to support her clinical work and research in the areas of family health and functioning. She's directed the Infant, Child, and Family Project and has a program that's been instrumental in improving the health of young infants and their families throughout the San Gabriel Valley and the surrounding areas. She's authored over 30 research reports on intervention outcomes and is a PI on the study on high-risk infants commissioned by the State Department of Health in 2000. She continues to serve as a consultant in strategic planning, program development, and evaluation in the areas of health, education, and social services. She's established benchmarking for physician practice in our local hospitals, designed evaluation studies for Healthy Start programs, federal and state-funded substance abuse treatment programs, domestic violence shelters, and services for victims of abuse. As a dean, you can see her commitment to research, and she's strongly encouraged the School of Nursing, both faculty and students, in their trajectory of research. And she's been instrumental in grant funding here in the School of Nursing. I'm so pleased to turn it over to Dr. Lesch for her words. Thanks.
Well, thank you, Renee. I always feel tired when you do that, but I've been around a long time, so I guess it does add up over time. Let me go ahead and share my screen, see if I can do this correctly. Here we go. There we go.
Perfect.
So So it's my privilege, first of all, to also say special thanks to Dr. Benner. We so appreciate her expertise and her participation in the Research Symposium. You know, every time I listen to Dr. Benner, I learn so much. And so it's an extremely, I think, wonderful and exciting opportunity for her to speak to all of us here at Azusa Pacific University. I also want to take just a few minutes to thank Dr. Brent Wood and the Research Symposium faculty and staff committee who have worked so diligently to bring all of you these amazing presentations. And I just feel very fortunate that we have them here at the School of Nursing. So it's my pleasure today to share with you some of my brief but critical reflections on leadership during the pandemic. And it's primarily, I think, something that took all of us by surprise. I know from like all major events that happened in the world, you know, all of us sort of recall where we were and what we were doing when the COVID-19 pandemic hit and we were told to shelter in place. I had taken a brief vacation and had flown back to the United States, and it was like coming back to an altered reality, that one that I had left a very different reality. My world had changed, and it had changed in incredible ways. So lockdown started 2 days after I got back, and everything we were accustomed to doing and participating in changed overnight. And it was not only just the toilet paper, right? That's one of the big jokes around. That's one of the ones that people stood in long lines to get. It was just the fact that everything changed. Our access to resources changed. And this is not the first pandemic, nor the first global infection that we experienced, but the impact was very striking because we had read about the Spanish flu in 1918 and the 2-year trajectory that it took for that to resolve. Many of us experienced HIV and AIDS in the 1980s. Certainly a lot of us still remember the initial SARS epidemic. Ebola was very frightening. Zika was not too long ago. And COVID-19, of course, is the one that hit just last year and changed everything for across the globe. It's not just in the United States, but across the globe. So COVID-19 was a critical, unparalleled global health crisis. And I think it's really important to realize that yesterday, 148 million plus individuals had contracted COVID, and 3 million had died over the past year as a result of that. But the light at the end of the tunnel was that we're almost close to having administered 1 billion vaccinations. And so that really is an amazing step towards hope and progress. Daily cases in COVID go on. You can go on the internet and on a daily basis track the cases in COVID and look at the graphs and the progression. We can certainly see that the Americans are still very impacted. We have not significant improvement in California and some of the other areas. We're certainly seeing an opening up, but we know we have not reached the end of this pandemic. And during the during the pandemic and the health crisis, we look to our government and our healthcare providers for leadership. And COVID-19 was a leadership test, and by all measures, it came back negative, right? And that was not just in the United States, it was a global negative. Should the leaders have known, should the leaders have known what, and should they have been better prepared? Should they have kept us safe? These are all valid questions we can ask, and we should be asking. COVID-19 as a leadership test was a failure. And if you take a look at, I've just got 4 citations here, but I can give you hundreds of citations on where the lack of leadership failed. So an amazing article, Sadness and Disbelief from a World Perspective, dying in a leadership vacuum. Global leaders prolonged the pandemic. Lack of leadership in vaccine effort has failed not only Idaho, but areas across the United States and across the world. So when we look at leadership and the impact the pandemic had on the world, we realize that our leadership was ill prepared to deal with its devastating consequences. And what we saw firsthand was the importance not only of those who had leadership skills, but the impact of those who had an absence of leadership skills. In March and June of 2020, there was a world leader approval rating. And I think this is interesting to look at because it shows that in some areas where the ratings started off very low but increased, like Australia and Germany, we saw leaders who actually took action and created and improved the situation for their state, for their nation, and for their citizens. We saw other areas, like in Brazil, where they started off strong, but as it progressed and as it became clear that leadership actions were failing, the decline in leadership, and this has continued even into the present moment. And in the United States, we saw, a relatively absence of leadership that continued on throughout the pandemic. And again, this was in the early 2020s, but that again has changed with a new leadership in place, and we're seeing more hopeful changes in that particular area. But the World Leadership Approval Ratings tell us how important leadership is in preventing illness and preventing death across the world. So what went wrong with global leadership? I think we know, we can see it in a lot of our actions that were delayed and were not initiated quickly enough. There was inaccurate and conflicting information. The lack of resources was especially difficult, and that was also as it pertained to protection and inequality in appropriating resources still are present, and we're still dealing with that today. Policies were weak and inappropriate. We saw adherence to opinion leaders rather than paying attention to expertise in science. We didn't have the ability to test effectively. We didn't have vaccines. And most of all, we failed to use the hard work of our healthcare providers wisely. And so sometimes resources were redirected in other areas rather than at our healthcare providers or at our hospitals against those that bore the brunt of the difficulty and the illnesses that were being experienced across the nations and across the world. Failure to use healthcare providers and failure to resource healthcare providers had a major impact. So today I wanted to reflect on leadership in nursing and healthcare during a crisis, and to also recognize how the political arena influences that, as well as to identify the importance of effective leadership styles, and to help you look a little bit at different leadership styles, but primarily the construct of ethical leadership, as well as to identify some competencies in order to initiate change and establish resiliency, because this is not going to be the first or the last epidemic that we will face. So why is nursing leadership important? Well, first of all, the pandemic is chaos, complexity, and uncertainty. Nurses are the largest healthcare provider group, and they provide healthcare on the front line. The significance of the nurse's role and the nurse's contribution is much more relevant than we can imagine, because they are the cornerstone of healthcare. And most nurses that were in practice today did not know what to do in a pandemic. They had not experienced this, and this was uncharted territory for them. And so it wasn't like we could go back and say, this is how you need to act. They had to find that out on their own. When I looked at the research and in preparation for this particular presentation, I was looking for research about nurse leaderships, particularly in a crisis, thinking we could relate that to the COVID-19 crisis. But what we find is that there's really a lack of research in nurse leaderships, and particularly nurse leadership in the healthcare crisis. And so there still remains questions that we ask today that we need to explore. So how do nurses lead in a healthcare crisis? What are the challenges that they have to overcome? And how do they overcome them? How do nurse leaders respond to and recover from a crisis such as COVID-19? And what are the nurse leadership competencies that we really need to be working on to develop? My premise is that every single nurse is a leader. Every single nurse leads in the setting or the situation in which they provide leadership may change. The level of leadership may change, but they are a leader in change. They are a leader with an individual patient, with an individual family, with their particular unit, with their amazing healthcare organizations, with their systems of organization, and even with global healthcare. Nurses function in a leadership role in healthcare, and I think we both need to recognize that and own that leadership. Research shows that leadership in healthcare, and particularly during a crisis, requires values, visions that turn into action, communication, and caring relationship. Values, vision, action, communication, and caring relationships. So when we ask nurses to lead in a crisis, we're asking nurses to show that, to show and be clear as to what their values are, to have a vision for, and to move into action, to communicate well, and most of all, to continue to establish and maintain caring relationships. So what are the characteristics of an effective leader and their leadership style? Well, I want to talk a little bit about four leadership styles. Ethical leader, which I think is foundational, and then a variation on that is a transformational leader, the authentic, compassionate leader, and a servant spiritual leader. And I think it's important to realize both the components of an ethical leader and the differences that the different styles bring to someone's leadership abilities. So an ethical leader is linked to personal characteristics such as honesty, integrity, trustworthiness, professionalism, and dependability. So we look at an ethical leader as having the personal qualities to be a leader, and these are also the qualities that a nurse is expected to have. Nurses are expected to be honest, to have integrity, to be trustworthy, professional, and dependable. And when we, of course, see polls on who is the most trusted person in most professions, nurses rise to the top of that. The second thing about an ethical leader is their motives. They need to be fair and principled decision makers who care about the individual and society and who are willing to live out their principles. So this is the quality of altruism. And motives make a difference. If your motives are for principled and fair decision making, your leadership will reflect that. Moral managers, ethical leaders, communicate ethics and values, and they hold their followers, those who they lead, accountable for their actions. Moral managers communicate, and it's really important that they communicate these ethical and value messages clearly. And exhibit in their own behavior and in their own personal interactions and interrelationships and role modeling those behaviors that we expect them to also articulate and communicate to those who follow them. So ethical leaders, I think, focus on emphasizing moral management. Moral management is based on principles and ethics, and moral management needs to be communicated and individuals need to be held accountable for that. But there's an important component to that that we don't always appreciate. That's the values need to align with the values of those that are being managed. And that's not always the case. And I'm thinking about the situation, even in the United States here, about vaccinations. Can an ethical leader, and I'm raising this as a hypothetical question, can an ethical leader approach a situation such as vaccination from a moral leadership perspective and not believe in vaccinations? And the answer is yes. If they have certain principles and they believe vaccinations are dangerous, that ethical leader could advocate for that. But the dangerous part of that is that even in their moral management of their principles, they are impacting the health of the nation. And a good example of this is in Brazil. And if you remember the leadership graph that showed that Brazil was high in leadership, but dropped significantly over time. The president in Brazil is very much opposed to vaccination, is not implementing a process of vaccination, and is endangering the lives of many of his citizens. And as you can see, that the approval process and the respect and the ability for that person to lead has started to drop, even though he's following his ethical beliefs. And so one of the most important things about an ethical leader is that the values need to align with the values of those being managed. And that's really important distinction that we need to appreciate when we start talking about ethical leaders, because that is the critical component of moral leadership. The second thing is that motives matter. Motives are based on fairness and principled decision-making. Motives that care about people, or altruism, places the well-being of the population and the individuals in that population ahead of one's own. Moral management should be focused on those type of values. But as we know, and as we look at the unrest in the world and in the United States today, we know that people don't always believe that leaders have motives that care about all the population. We see a lot of unrest around motives that only apply to a certain segment of the population, or that ignores the needs of others in the population. And so motives matter, and we need to be sure that the motives are based on fairness and principled decision-making. Ethical leaders model the principles and ethics in their personal life. And we've seen this now in our own leadership in the past year, that often the things that we expect leaders to model are not the personal actions that they exhibit in their own lives. When we started to roll, another example, again, staying with vaccinations as an example, when we started to vaccinate, we saw nurses and doctors and political leaders step up and take in a visible and filmed manner, vaccinations, and saying, I am role modeling for you that I think this is an appropriate behavior. I'm taking a personal action because I think this is what we need to do. So leaders guide ethical behaviors and establish standards, but they also model those standards in their behaviors and experiencing the consequences of those actions. And so we look to leaders to model the principles and the ethics in their own personal lives. And we question leaders where that's not present. So when we look at ethical leadership, then there are similarities with ethical leadership in almost all forms of other leadership styles, because ethical leaders are actually ethical leadership is actually foundation for many of these other leadership styles. So what are the key similarities? They're concern for others, altruism. And transformational leadership has that same concern. There's ethical decision-making, there's integrity, and there's role modeling, and that's shared with transformational leadership. So what does transformational leadership add that's different? Well, the key difference is that they emphasize vision and the values that drive that vision. They focus on growth, development, change, and intellectual stimulation. So transformational leaders are forward-looking. They identify a path forward. They talk about where we need to go. They talk about how to get there, what we need to do to get there, and what are the steps we need to take. In the pandemic, we could really see the difference between people who were able to articulate that path forward and those who could not. And that's a different type of leadership, but very important. Transformational leaders emphasize the vision of where we should be and where we have to go. Transformational leadership is going to be very important when we get towards the end stages of COVID-19, hopefully. And when we start talking about where is the next pandemic going to come from? Because transformational leaders need to be able to shape the change that will prepare us for the next step. And we know there's going to be a next step, right? So transformational leadership is an important part of what we expect our leaders to have. And nurses are able to exercise transformational leadership. Dr. Benner spoke about how nurses need to articulate their experiences and what they've learned. And transformational leaders take that experience and say, this is where we need to go in order to prevent that for the future. Authentic leadership is, again, concern for others, ethical decision-making, integrity, role modeling are core foundations of transformational leadership. But what's different here? Well, authentic leaders emphasize authenticity and self-awareness. Again, Dr. Benner spoke about that in teaching and clinical learning. And so nurses learn to do this, but we also need to do that in our leaderships. We need to examine and reflect on our own behaviors. We need to strive for consistency with our values. So what are the key differences between an authentic leadership and some of the others? Well, there's an openness and a humility in authentic leadership that we may not see in other areas. The humility around being vulnerable themselves, about not having all the answers, about being open to others, providing answers. Authentic leaders stop and examine their motives, stop and examine their awareness of what others are saying and their ability to interpret that. They reflect on what they're doing and they strive for that congruence with their values. An authentic leader is an amazing role model because that openness and that self-awareness and that humility allows them to engage with others in the process of leadership. So authentic leaders are ethical leaders, but they also add a different dimension to that. And servant spiritual leaders, again, same areas, same similarities as with the ethical leader. But what's the key difference here? Spiritual leaders emphasize not only the visioning, but they have a different type of visioning. Their visioning is one that's based on hope and faith. They see their work, they see their role as a vocation. They see their role as being something that not only they were chosen to do, but they chose to do that. The profession of nursing for them is a chosen profession. More than anything else, a spiritual leader has meaning in terms of their work and their leadership and their profession that is derived from their faith. At Azusa Pacific University, we base that on a Christian philosophy, a Christian worldview. it doesn't have to be a Christian worldview. There are many other theologies and faiths that envision hope and faith and draw on meaning. There is an awareness that there is a greater power, that there is a God that directs our lives and creates meaning for us. And so we are part of a bigger picture. We are part of a world that has a significant and an important role. And we are fulfilling that role. In Christianity, it may be one that where we take Christ as our model, and we fulfill our role as a leader by modeling ourselves on Christ. And we derive meaning from our work because of our Christian faith and our values. But it could be a Buddhist, it could be a Muslim, it could be a Jewish faith, it could be any other faith, or it could be the absence of faith, but still a deep spiritual commitment to a meaning that's greater than oneself. The meaning that arises from that also saves us in lots of ways from burnout and from despair and from moral distress, because it puts a context in our leadership that is greater than ourselves. And so when we feel personally responsible for so many things, having a context in which we are part of a greater whole is a protective factor as well, and allows us to function in some very, very difficult and overwhelming circumstances. And many nurses draw on their spiritual leadership as a way of maintaining their role as a nurse during this very difficult crisis-filled moment. So what is your leadership style? Where do you fit in? What type of leader do you want to be? And most of all, how would you like your leaders to act? These are important questions we need to answer, not only for ourselves in our own leadership role, but for those we choose to lead us in other roles. Where we choose to work becomes very important. Ethics, values, motives, vision, relationships, caring, openness, all of that matters. It matters in our day-to-day operations, it matters in our practice of our profession, and it matters in our leadership style. The absence or ineffective leadership, so the absence of leadership or ineffective leadership creates moral distress. It creates burnout, it creates depression, and it can create many other mental and physical problems in our healthcare workers. So how does it do that? Well, when you take a look at that, moral distress occurs when someone in patient care knows the correct procedure and is not able to act on it. Moral distress occurs in leaders when the right action is not pursued, either because of error or lack of judgment, or because the decision might have been made at a higher level beyond one's control. Moral distress is experienced for self when we do not or cannot protect ourselves or are unable to protect the ones that we love. So moral distress is when there is a dissonance, a disconnect between what we know we should be doing and what we can do, what we have control over doing, what we're able to do in that moment. And so I would say that during COVID-19, our nurses experienced significant moral distress because there was a disconnect between what they knew they should do and what they could do. And leaders experienced a significant moral distress because there was a disconnect between what they thought they should be doing and what they were able to do. And even as we were not always able to protect others, and even ourselves sometimes, from the impact of COVID. And moral distress drains individuals both emotionally, physically, and spiritually. It's not just that you feel upset, it's much more than that. It's an entire physical impact that, and I think some of our earlier speakers really talked about some of what the nurses said, and what they were really talking about was a moral distress, a disconnect between what they knew they should be doing and what they could do. what type of leadership helps protect them in that instance? And it's a leadership that's based on a spiritual foundation, a servant leadership foundation, which says that there is a greater meaning beyond yourself and beyond the situation in today's world. So there are leadership competencies that we can develop and that we can encourage our nurses to have in a crisis moment, and can help also to help nurses manage their moral distress in self and in others. First of all, I need to say that trust your clinical skills and your judgment. And if you are not sure, ask questions and rely on others to help you in that situation. Manage your fear. Fear immobilizes. Fear really paralyzes in individuals. You need to manage the fear of the unknown, the fear of not knowing what to do next. Draw on the skills you have and show respect and acknowledgement for the individual and for what you know. Acknowledge the courage of those around you. Acknowledge and respect the teams and the caregivers and the leaders that are in the trenches with you. Stay focused on what you can do and be realistic about what you can do, because often our expectations of ourselves are so much greater than what we can actually do. And when we hear nurses, sometimes all a nurse could do would be present. And she was present. And she was really courageous and successful in being present at that moment with that patient. When Dr. Benner talked about how they were with families, stay focused on what you can do. You cannot bring that family into the clinical setting, but you can be present with that family and give them the information and the care and the concern and the assurances that they need. Be realistic, because realism tells you that you are limited. You have boundaries, you lack resources. Be realistic about what you can and cannot do, and do not become overwhelmed by the fact that you are not able to be everything to everyone. Identify short-term wins in your competencies. It's so important for you to say, this went well, I did this right, and to acknowledge that in your fellow nurses and in your fellow healthcare workers. And then control the stress. Now that sounds easier said than done, right? But, give up that stress. And for those who have a spiritual leadership style, give that stress to the Lord. Give that stress to a greater power. Give that stress up and do not internalize that. Be willing to adapt. Be open, be flexible, be willing to adapt. And look for areas that you can control, where you can have a sense of salience and power in that situation. Be authentic in your leadership. Check your actions. Grow your moral identity. Well, what does that mean? First of all, you have to be self-aware. You have to reflect. Take time to reflect on what happened. Take time on what went right, what went wrong, how did I behave? Self-awareness is one of the most powerful change agents that you can have. Sometimes when we think of individuals changing, what is it that makes the difference? Well, they suddenly become aware of what they're saying or what they're doing in a way that they weren't before. And so self-awareness is a powerful change agent. Grapple with ethical issues in a sophisticated manner. Do not pass rapid judgments. Do not assume. Make decisions based on altruistic and contextual information. Look for the context in which a situation has taken place, and grow your moral identity by being contextual, and also by having an outside source. So in spiritual leadership, there is an ultimate source of right and wrong. There is an outside source of right and wrong, and it's not just your own personal decision. make decisions on the context of a particular situation in full awareness of what your moral values are. And then develop your own leadership style. Become aware of your own personal characteristics for leadership. Again, self-awareness is so important here. But everyone is different, but we all have characteristics for leadership. And what are yours? And when you look at the different styles, and when you look at ethical leadership, you can and when you look at your role as a nurse, you can see that you have amazing characteristics for leadership. Know your code, your professional code of ethics and your standards, and adhere to your standards. That's your moral compass. And you know that you have an obligation to those you care for, and that your profession has established standards for that, in addition to your own personal values. In developing your leadership style, seek additional education and competencies. One of our early speakers talked about the fact that education and experience influence how well nurses did and their ability to navigate through COVID. Education and competence, and it helps develop your competencies. Experience helps develop your competencies. One of the things that is the most amazing thing is that the mentor you select and the one you role model yourself on is the most powerful influence in your leadership style. And they looked at early childhood characteristics, and researchers looked at later in some of the education and later influences, but it was the mentor you selected that you identified, this is the kind of leader I want to be, and this is the person I want to help guide me in that leadership. That is the person that's the most influential in developing your leadership style. So select carefully the mentor and select carefully the type of leader you want to become. During a crisis, there are some basic action steps that our nurses need to take, and that will help them manage during this crisis. The first one, we've talked about it earlier, is know your values. Know your values and assign meaning to your experiences. Maintain your moral compass during critical decision times. I cannot emphasize that enough. Maintain your moral values during critical decisions. Don't let go of that. That gives you integrity, and that gives you good decision making. Communication is one of the things that we really need to emphasize. What is truthful and what's relevant? Give voice to the new realities, no matter how difficult. Be truthful and be relevant, and be brief. We don't have to say a lot. People want to know. They want to know, and they want to be able to count on what you say. Balance the needs of the staff with the needs of the patients, your fellow colleagues in nurses, the respiratory therapist, the physical therapist, the CNA, the IT tech. Balance the needs of others with the needs of the patients, because the environment that is healthy and that is supportive supports patients, families, and nurses. And be creative and visionary. Adapt ways to engage your patient and the family into new care situations. And most of all, into new operational policies. We are looking to our nurses to be creative, and it's not just in clinical reasoning that you need to be creative. Identifying what's new in the care situation and how you need to be different moving forward, and what kind of policies need to be in place. That's different. There's lots of examples where nurses were initiated major policy changes that improved patient outcomes. I want to just emphasize a little bit about communication and clear and relevant communication. You don't always have to have all the information. You will not have the answers in a rapidly changing environment. In fact, I found that I would say something one day, and 2 hours later, it would be changed already, and I would have no influence over that. So you can qualify that, but give information. You can say, to the best of my ability, based on these facts, as of this moment. Place information in context, and more than anything, acknowledge the feelings of how frustrating it is when things change so rapidly, and when you don't have control over those changes, and when you really don't know from one moment to the next what's real for you. You know, I also want to sort of focus a little bit on the fact that we are not able to communicate in this virtual world that we now live in, what we're experiencing right now with me many miles away on a screen talking to you. Our communication is remote, it's digital, and it undermines social cohesion, it undermines social presence, and it reduces feelings of personal responsibility. We can't always identify subtle emotional cues or reactions or nonverbal communication because we only see the part of a person. And the quantity of communication is diminished. It's very one-sided. It's not interactive. So we need to have a real commitment to increasing communication in its richness, its frequency, and most of all in synchronicity. And when we're not able to communicate in person, and that's both in teaching, but that's also in when we communicate to those in patients, when we communicate to families, and when we, we try to communicate in any kind of a learning situation. Frequency, synchronicity, trying to introduce social presence and reduce feelings of isolation is so important in communication. And it's a challenge in digital communication, but it can be done. And finally, I would say, try to influence the organizational environment of the system in which you work. You can communicate values and standards. You can empower ethical behaviors by your own adherence to them and your support of others who are engaging in that. We can design environments that are conducive and supportive to ethical behaviors because we can create policies and procedures that allow people to identify concerns, to speak openly about things that are not going well, to recognize failure and to support change in that environment. Teach others to think about ethical questions by raising the importance of consideration of context and understanding and an openness of dialogue about what is that particular concern and why is it important and how's there a different way of looking at it. Hold the culture and yourself and individuals accountable for being ethical. You just need to, call yourself and others when you see them behaving in manners that are not supportive of patients, that are not supportive of each other's, that is not the care and consistency with ethical leadership that you should be having, which questions motives, which questions principles. Establish trust, and more than anything, communicate meaning and purpose of what you're doing, because that really allows people to not only establish trust, but to also understand the differences and the rationale behind your behaviors. Mother Teresa said, and I love these two quotes, and I'd love to include it I think it's sometimes, just like you need a mentor in your leadership style, also look at mentors in the environment around you. Mother Teresa is one of those mentors. Do not wait for leaders. Do it alone, person to person. What a great quote that is. Do not wait for leaders. Do not wait for others to tell you what to do. See it and do it. You are a leader yourself. And then we ourselves feel that what we are doing sometimes is just a drop in the ocean. But the ocean would be less because of that missing drop. We don't always appreciate how important that one thing is that we do, that one word that we say, that one example that we have. You are a leader. Thank you so much for having an opportunity for me to reflect on leadership and give me an opportunity to share my thoughts with you. I so appreciate each and every one of you. And I'm just hoping that this will guide you into just a different way of thinking of yourself, not only as a nurse, a caregiver, but as a leader in the healthcare profession.
Thank you, Dr. Lesch, my friend Aya, for giving us such a great perspective on who we can be, even in a crisis. There's one question that I think is relevant right now to this item, and it says, what is your personal evaluation of nursing leadership and administration, particularly in higher education, in response to COVID-19? What was done well, and what do you think we could have done differently?
Wow, that's a great question. Let me just stop sharing for a moment. Oh, it looks like they did that for me already. I'm a little slow on this, right? There were lots of things that were done well, you know, and there were lots of things, a lot of examples of failure. So let me talk about some of the examples that were done well. I think when you saw people in leadership positions saying, this is the reality, this is what we're dealing with, this is what I think you need to do in order to deal with it. So Dr. Fauci, you know, very controversial, but he didn't pull any punches. You know, he basically said, this is the reality and this is what you need to do in order to deal with it. When I use the example of people using opinion leaders and not expertise and research, there's there's a presence, I think, in the United States right now of giving authority to opinion leaders who have no basis for their opinion other than their personal feelings. And I think that is a great example of where leadership can go awry, because these are often people that are in positions of power. But if what they're expressing is their personal opinion and there's no foundation for that, that is ineffective leadership. And that can be dangerous leadership, because people that operate on those statements can often engage in behaviors that are dangerous to their own health and the health of others. And so I think that's an example where we have to, respect the research and respect the leaders that base their opinions on solid evidence-based practices. And we in nursing, I know, have emphasized that in our education of our nursing students and all of the nurses on the units. You know, when you give a treatment, when you, approach a patient with a medication or with any kind of an intervention, you want to be sure that this is not just your personal opinion that you're doing this, but that this is based on sound scientific evidence and practice. And that's the role of leadership, is to articulate that and move that forward.
Thank you, Dean Lesch. How has the devaluing of public health and the resultant lack of funding contributed to the lack of effective response to the COVID pandemic?
It's been devastating. It's been devastating. Whole institutions were dismantled that were established earlier. We have known that a pandemic is coming, and we should have been prepared. We should have been prepared. This was not something, and this is one of the reasons that I think it's so important to not let this opportunity pass. We as leaders in healthcare need to make sure that we are prepared, because this is not going to be the last epidemic. And so we will have a huge failure in our own leadership style if we allow this opportunity to lapse and if we repeat the mistakes of the past. And so, it's amazing. The United States had the technology, the savvy, the infrastructure, and we did not implement that or utilize that or exercise that. And we fell way behind because we did not mobilize that. And so I think it's a great lesson for us, but it's also a lesson for the rest of the world that we do need to anticipate that this can occur again. It will be different, but there will be some similarities to it, and we need to prepare for that.
Okay, I'll go ahead and read a second one, if you don't mind. We have heard ethical dilemmas faced by bedside nurses related to the lack of resources resulting in moral distress, as you reflected upon. For nurse leaders who are seemingly impotent to obtain needed resources for their staff, they too were impacted. For the future, what wisdom would you offer nurse leaders on how to more effectively deal with this issue?
Well, it's interesting, you know, because this is a first for the United States, but it's not a first for the rest of the world. In 1993, when I took some of our first group of students to what was then Burma, and we worked with the Karen tribe, and we realized, you know, there was a woman that came down she had about a 2 or 3 day journey along the river that runs between Thailand and Burma. And she came to our clinic where we were at, and she had experienced a pregnancy and delivery, and she was experiencing postpartum hemorrhage. And there was only one vial of Pitocin left. And I gave her the last vial of Pitocin that was available. And so I knew I could help this woman, but I could not help the next one that's coming. And this is a powerful lesson for our students that we have been so fortunate in the amount of resources we've had in the United States, but in the rest of the world is not that fortunate. And so I think it's been a devastating lesson in our leadership is how do we deal with patients and how do we deal with healthcare in an environment where we don't have what we think we need in order to provide that. And we fall back on what we do have and what we can do. And we have to forgive ourselves for not having the resources. Now, even if we forgive ourselves in that moment, we have an obligation to plan for the future, make sure that those resources are available for ourselves and for our patients and for the rest of the world. But that is where the power of spiritual leadership really comes in, because you have a broader context for that. You have a context of forgiveness and allowing someone to do the very best that they can and know that they've done the best, and rewarding and encouraging those in that moment. And so those in leadership who didn't have the resources, they needed to communicate that. They needed to care for their fellow nurses, but at the same time, they also needed to do the best they could with what they had. And then at the same time, not hold that internal guilt and commitment that they couldn't do better on that, and to allow themselves that level of forgiveness.
One last question.
Hey.
There's a question about, as a result of COVID-19, do you see the possibility of a greater impact for nursing leadership and nursing voice in the future, in clinical contexts and in political contexts?
I think we absolutely need to do that. I think there is a greater possibility, but it won't happen unless we make it happen. And we need to own our voice, we need to own our leadership, and we need to own our knowledge, and we need to speak up. We are one of the largest groups in the, professions in the United States. And we are knowledgeable and we know what needs to happen, and we allow others to silence us. And so I think it should happen, it ought to happen, but will it happen? It will depend on the nurses that have experienced this and who are willing to step up. You remember what I talked about, that you are chosen to be a leader, but you also choose leadership, right? And it has to be both. Sometimes somebody can give you responsibility, but unless you choose that leadership and you embrace that and you move forward with that, you cannot change. You cannot be the kind of transformational leader that you need to be. And every single one of you can be a transformational leader if you own and choose the leadership that you're capable of providing. And it will be different for each of you. But nursing can change this if we speak up, if we own our voice, and if we articulate what needs to be done.
Okay, wonderful. Thank you, Dean Lesch. Thank you, everyone, for joining us this evening. A survey will be emailed to all of you who registered for the symposium. This survey will ask for general feedback on the presentations, and there will be more in-depth questions for those that are seeking continuing education, all in the same survey. When we sincerely request and hope that you'll respond, as we will take your input seriously as we plan for next year's research symposium. If you go to the Research Symposium website, you can already access the survey, the evaluations, the recorded sessions, and so on. So finally, I want to thank Dr. Benner and Dr. Lesch for their thoughtful presentations and reflections this evening. Clearly, there's much work still for us to do in nursing and in public health education, as well as in the professional work that follows. And I especially want to thank the remarkable faculty planning committee members and the many staff members, including Jeff Polstelmeyer, Jasmine Lord, and Jonathan Lord, that have done work tirelessly and broken new ground to make all of this happen. So to all of you, we pray that these sessions have provided an accurate account of the lived experiences of nurses and healthcare professionals, along with the patients and family members during this terrible pandemic. But we also hope that you have found some hope and encouragement from the personal testimonies and the survey results as you continue your nursing and public health education and your work in these vital fields. So thank you for staying with us. It was nice to have this extended with the quality of the discussions and considerations. Thank you for being here, and we wish you all the very best. God bless you all.